Okay. Hi, everyone. This is Indira and Abby from the Maternal Child Health National Network, which is a national coalition of early career public health professionals working to uplift important topics and advocacy in the maternal child health space. I'm Indira. My pronouns are she and her. I'm a graduating Master of Public Health student at the University of California, Berkeley, and I'll let Abby introduce themselves.
I'm Abby. My pronouns are they, them, and I am a project manager of transformation and strategy for the Urban Health Initiative at the University of Chicago.
And so a few months ago, our newsletter theme in the Maternal Child Health National Network newsletter was cancer disparities. And we put a spotlight on the Dream Lab at the University of California, San Francisco. The Dream Lab focuses on tackling health disparities through a multi level approach, considering physical, social, and structural factors, including place in health, the role of cancer surveillance, and genetic and molecular epidemiology. One tool they have recently launched to visualize social determinants of health is the UCSF Health Atlas website. To learn more about the Dream Lab, cancer inequities, and the Health Atlas, we would like to welcome Dr. Debby Oh, a data scientist from UCSF, to our conversation. Debbie earned her PhD in epidemiology from UCLA. She holds a master's degree in public health nutrition from the London School of Hygiene and Tropical Medicine and a bachelor's degree in molecular biology from Princeton University. Thank you so much for being with us today. How are you, Debbie?
I I'm excited to be here. I think this is my first podcast ever, so thank you for this chance, for my 5 minutes of fame.
You're already doing amazing. So I'll go ahead and take the next section if that's all right. We're all new to podcasts, so this is going to be just like super cool and fun. So let's start from the beginning. How did you find yourself working at the intersection of cancer disparities, data science, and mapping?
So I took kind of a twisty turny road to get here, but I am so glad that I am here. As a child of immigrants, of course, my parents wanted me to be a doctor. But I was never really into blood and guts. And, like the more I thought about it, like it just didn't seem interesting to me. But I did major in molecular biology and I was kind of like thinking through what my options were, and it wasn't until my junior year of college that I actually even heard of public health. But once I heard of it, I was like, something clicked. I was like, that's it, that's what I want to do. um and I honestly, I feel a little jealous of people like Indira who kind of grew up in this era where public health was like a major, and it is exciting to me as a public health person to now see that it's grown as a field. Okay, so in a case, I learned about it only my junior year, and then I went on to do a master's in public health nutrition. And then I kind of bounced around and did a lot of different stuff. I worked in hunger issues. I did do a little bit of cancer research with um, the WHO. It's called the IARC, the International Agency for Research on Cancer. So I did dabble a little bit in cancer research, but my PhD was actually on HIV/AIDS in Asia.
Mm.
So yeah, I bounced around a lot, and then um, I in San Francisco, I worked in the Bayview, which is actually not too far from UCSF, and I worked in childhood adversity issues. Um, and as I got through all these different things, I started thinking through, okay, what am I good at, and what am I interested in, and kind of along the way, I also had to pay rent.
I mean, but you can also already start to see the through line between all those things, like working in really impactful organizations, working on, HIV/AIDS and hunger are things that impact health equity and people who are marginalized in society. And so, like, even without you like telling us like how you put it all together, it's easy to kind of see where your heart is in those spaces and how you're like, let's help people. I don't know if this is the way you think about it, but let's help people have a good life and have access to health and the best for themselves and their families.
um, Yeah, I don't yeah, I definitely have always felt the need to make good use of, the experiences, the training, the positions of power that that I hold, but it took a while to figure out kind of like, well, what am I best at? And how can I use these things, right? But
Yeah.
along the way, so again, I needed to pay rent, and for a long time to pay myself through, my various graduate degrees, and kind of just for fun. Um, I worked for a company called Blue Mountain Arts, and I illustrated like children's books. We like made greeting cards. I had a whole bunch of like greeting card things going on. Um, I mean, there's weeks where I would just like design buttons for websites. So,
Wow.
but but it was really interesting and fun, and I made it through grad school without a ton of debt. And then at some point I realized I'm like, these are not totally separate things. Like there is a place for, good visual design in public health, and it can come in many forms. It could come in a very impactful, you know, social media campaign or a good website. But it also can come in maps, right?
Yeah.
Um, so so that's kind of like where I started to wiggle myself. And
Yeah, and you'd already been being trained like in accessible formats, with working with children's books. It sounds like, part of that from, just my outside perspective is that that children's illustrations need to be visually accessible.
yeah, and I think in some ways I think of it as the same thing where I maybe sometimes oversimplify things, but like epidemiology is a lot of like zooming out and seeing like, oh, what is the big picture? And kind of similarly for illustration, you kind of want to zoom out and be like, oh, what is the, idea that I want to convey with this
That's
illustration or
amazing.
whatever. Yeah. Um, in any case, that's kind of how I got to where I am currently because I found a position at UCSF that was really interested in developing out, data visualization and I'm just like really excited to be doing this work. Even though I have to say it is a very, very challenging time to be in academia. I feel like this is the right place for me um, for the skills and experience that I have, and I feel like I'm just grateful to be here.
We're recording this in April of 2025, and this is a very challenging time to be in academia, to be in any publicly funded sort of work, and in public health in particular. So I appreciate that, you're here, you're showing up, we're all showing up, and like continuing to do our best work. If it's okay, I'll ask the next question, then I'll switch it over to Indira to take a turn after that. So let's start talking more specifically about the Dream Lab now that we kind of, understand what little bit about what led you here. Dream is an acronym, is that correct?
Right. So it stands for Disparities Research Environment and Multi-omics. So that I mean, it's a kind of a mouthful, and honestly, I often forget what all the different pieces mean, but it gives a flavor for what our team does, which is a lot of disparities research, looking at neighborhood environments and looking at kind of like the genetic aspect of things. But we kind of had to play with the words so that it would turn into something and then made like a cool logo for ourselves and all. That's
That's
what
like
I
half the
remember.
work of academia is like, can you make your work into a title that leads you to an acronym that all still makes sense? They should like give everybody a class in that. So great work. You made an acronym. It works. It makes sense. Thank you for telling us what that stands for.
Cool. So I will jump in. Could you walk us through just some of the projects that happen in the Dream Lab and maybe if there have been any particularly impactful projects that you have worked on in your time at UCSF, or just important work that you think is happening?
Well, let me take us back in history just a little bit so you can kind of understand where we got where we are. So the Dream Lab used to actually primarily be like most of the people in Dream Lab used to be housed at the CPICs. So the Dream Lab used to be the research branch of the Cancer Prevention Institute of California. Um, but when that kind of uh, that organization sort of dissolved and broke into like different pieces, the research team moved to UCSF. So already there was decades and decades of expertise in cancer data, cancer research, so there was a lot that was already going on before DreamLab even came into existence. Um, I was fortunate enough to work at CPIC for maybe 3 months before we transitioned over to UCSF. So I've been part of the DreamLab ever since the beginning, which was about 7 years ago. Um, so a lot of the work is rooted in our sort of like unique and amazing position of access to the cancer registry. And the cancer registry, if you don't know, has data on every single cancer case that has happened since 1988 in California. I mean, there are other cancer registries across the US, but this is like an incredibly valuable resource. And I often say it's like the closest thing we have to Scandinavian data, like the utopian Scandinavian health records. Like, we don't have any of this about diabetes, obesity, or, we don't have as good data that's like complete population data on anything else. But we do have it for cancer in some places. And so we hold this precious data and think hard about how we can use this to advance the health of the public. Um,
Can you tell us a little bit more about the epidemiological impacts of having this kind of a registry before we go into more specifics about the health lab?
sure. I mean, it it is a little daunting, to be very honest. um, because we are mandated to, have data on every single cancer case. It means that every year, people are trying to gather it from the different hospitals and trying to make everything uniform. And then something like COVID happens where it's really hard to get data, but you're still mandated to do it. Or you're changing over whatever programming system, and everything's in disarray. But in the big picture, like, we still move forward and we have years and years and years of data, and you can see trends over time, which is amazing. Um, Good and bad. You can see kind of like the impact of, some of the tobacco policy that has happened. Like, there are a lot of things good happening in cancer research because there's been a decrease in tobacco use in California. But
That's
you
so
also see
cool.
other more concerning trends, like, for example, breast cancer is going down in all groups, but you see it kind of creeping up in younger Asian American women. And if we did not have a cancer registry, we wouldn't necessarily know that, because still in my mind, I'm like, what my brain tells me is like, oh no, Asian women are not prone to breast cancer, right? I feel like that's kind of what I grew up with, thinking. But actually, if you look at the data, the trends are kind of creeping up. Um,
Which just kind of highlights the importance of epidemiological data really broadly and helps us understand like why this specific project, kind of how it's situated within the different ways data that we collect and why we collect data. So thank you so much for answering that question. I'll turn it back to India.
Yeah, cool. So just any impactful projects in the Dream Lab or some more specifics on your work in cancer disparities would be great.
Sure. And I guess maybe I can talk a little bit more about Asian Americans and cancer, just because that is a big focus of our group. We are situated in the Bay Area, which has a high proportion of Asian Americans. Um, and one of the projects that we are actually wrapping up recruitment in the next few months is the Female Asian Never Smoker Study. So another acronym, it stands for the FAN study. um, but it is interesting. This is again something that I didn't know, even though my grandmother had lung cancer and passed away. Um, I didn't know that Chinese women, like, of the Chinese women who have lung cancer, 80% of them have never smoked. Like,
Wow,
yeah, I didn't know. But if you look
that's
at the general
incredible.
population, it's more like 20%. Um, if you look at Asians in general, it's like about 57, 60%. So, something is happening there. And so our team put together a case control study, and we've been recruiting up and down California and just trying to figure out like what is happening there. And, hopefully, if we can have enough evidence, hopefully change some of the policies around screening, because currently the only way you can get screened for lung cancer is if you've smoked for 20 years.
Is it
Um,
because of cooking methods?
like that's one of the hypotheses. I mean, it could be
Yeah,
a lot of different things.
sure.
It could be
Yeah,
genetics, but it could be, like cooking at high temperatures, or it could be, yeah, it could be so many things. We're not sure.
sure, sure.
Yeah. Um, so that's kind of like one piece of work that I personally find impactful because of my own family history. But just because I think it's an important topic that is often overlooked. Um, and I'm excited to announce that as of 2 days ago, so on Monday, we started enrollment for what we call the Aspire study. It's an Asian American cohort study. So we were planning to follow 10,000, hopefully more Asian Americans over time, and to figure out what are the risks for what is putting Asian Americans at risk for cancer. And it's nothing like it has been done before. And so we're really interested to find out, what it is, but also it's it's kind of tricky. And I don't know if I'm Chinese American. Um, And cancer is a tricky topic to talk about. And so it'll be interesting to see how the community reacts. Because while it is the leading cause of death, some people like don't even know that like their family doesn't tell them they have cancer because there's such a taboo around cancer. Um, so I don't know if you saw what's it called, The Farewell of Aquafina? Was it
You
that
know,
one?
I heard of it. Yeah.
Okay, maybe we can edit this out, but in any case, and it is common for families to not talk about cancer. And if, for example, your grandmother gets cancer, the family might know, but the family might never tell grandma. Um,
Wow.
it's so I'm just speaking from Chinese culture. So I am really excited that we have rolled this out, and I'm curious to see what we find out and how it might help prevent cancer for the Asian American community.
That's really interesting, and I think those cultural, like, elements of, like, health education are really interesting. We have a project at U Chicago Medicine where we're working to help, our some of our Black residents. I mean, it's not limited to Black residents, but that's who is largely enrolled with hypertension management. And when we were developing the project, like, one of the things that we were developing the pitch to interest people in the project, and one of our community health workers was like, people don't think in this community don't think hypertension's a big deal. So when
Mhm.
you say, I want to help you with managing your medication to manage your hypertension, they're like, whatever, I don't care. Everybody has hypertension. I don't need to worry about it. And so really approaching these, health equity questions from a culturally competent lens is so important because everyone's impacted, but cultures are impacted uniquely by health conditions, and their reception to health education is shaped by those experiences. So thank you so much for your work in health equity and working towards making this research accessible to a population who needs the benefits of it but might have some significant barriers to access.
Well, I will let you know how things go. We're hoping we'll still be funded.
Yes, yes.
Yeah, totally. And I wonder if I can just jump on the epidemiology train for a little bit. So you mentioned it's a longitudinal cohort,
Mhm.
and I'm curious what exposures are you looking at, and how are you assessing them, and how are you getting at the maybe the more cultural aspect of like, is that something that you're trying to measure, or is it like qualitative or blood samples, or like just like more information about the study?
So currently, the way it's set up is the initial commitment is for a year, and that's 4 surveys. So the first survey has, you know, basic demographics, immigration. I mean, I think that would be specific to the Asian American community. But then we move on and we talk about things like stress, discrimination, diet. Do you have a more westernized diet, or do you eat more more foods from your home country? Um,
Hmm.
and what else? In a lot of physical activity. Um, I'm trying to think of other things, but we're hoping that it's a manageable set of items, and that each survey is about 20-30 minutes long. So it's a commitment of 4 surveys, 20-30 minutes out of your day. Um, and a small subset of those will be giving a saliva sample. And to be very honest, we wanted to get a lot more. We wanted blood, we wanted hair, we wanted everything. um, but unfortunately, we couldn't fund that. Like, it was just like too much money to be able to do all that. So the hope is, because it is a cohort study, that perhaps we will have funding in the future to be able to get some of these things, um, and maybe even do some qualitative work as well in the future.
That's super cool.
It's Aspire cohort.ucsf.edu. So it is,
Oh, okay.
I think it's Asian American Prospective
Oh,
Research.
I'm glad we looked it up because like I just did a quick search and found that, and that makes sense. That's
I know.
not it. So thank you
It was
for
again one of those exercises in trying to get the right acronym that got the right thing that not everybody else has used, but
right.
but we did like the idea of aspire, just like the positive framing of, we are aspiring for health for the Asian American community for generations to come. Um, and we have as our logo, it's a lotus, which is specific to many Asian American or many Asian cultures. Um, but what I like about this symbolism of a lotus is that it kind of grows out of the mud and it blooms like above the mud. Um, so in any case, that's just like a little hot tidbit for you.
That's amazing.
Okay, great. I think you touched a little bit on our next question, so maybe I'll just skip ahead a little bit. Is there anything that you, as with training in epidemiology and public health, that you wish people understood about cancer disparities that are kind of moving beyond individual behavior, right? Things like smoking, right? Or even individual genetics. Like like how do you bring your public health lens in to your work? And do you have like any like message or education for folks who are primarily thinking, I think as most people do, that things like smoking, having a certain diet, and things like that are connected to your health outcomes primarily.
Feel like you set me up perfectly for exactly what I want to say, which is place matters, right? And this is the reason why we put together the Health Atlas, which I'll tell you about later. But even if your individual, for example, even if your individual socioeconomic status is, one thing, the neighborhood that you live in also affects you independently. Um, and that's true not just for your socioeconomic status, that is true for a number of different things. And so this is not to say, your zip code determines your future and you're going to be stuck there for the rest of your life. But I think the way I think about it is that we need to think more holistically about how to approach health, and how to design our interventions that are not just, here, everybody, you need to come up with your individual physical activity plan, but it's more, we need to think about how to put, parks and pathways in place so that it's easy for everybody to get physical activity. Um, so yeah, simple answer, place matters.
Thank you. Thank you so much for that. And I'll say, like, many of us in the Maternal Child Health National Network are like working on our MPHs or our PhDs. And so it's really important to think about how we're addressing place in our public health work, and thinking about kind of policy advocacy and thinking about local mobilization for things like parks, and addressing social determinants of health, right? Building grocery stores and not convenience stores, right? And what that, how historically certain communities have not been set up for that, and how we can move towards that in the future, and like with communities, not for communities. I think that's super important for our approach to public health. Um, okay, what is something that you know now about data and health equity that you wish you'd known when you started, or maybe just an example of like growth and development in professionally during your career?
So I think something that I didn't fully conceptualize early in my career is um, how you communicate your results is potentially even more important than like publishing that scientific manuscript. Um, because if nobody can understand what you're saying, then it's like almost as if you didn't say it, right? Um, so I think this kind of ties into the fact that, I was interested in making children's books and graphics and things, but and thinking it was a separate field, but actually you really do need to have somebody who has expertise in how to communicate a message and you know, how to give an elevator pitch on what your research says, how to come up with 180 characters that will they'll be easily understood, right? Um, and I don't know if I fully understood that, earlier in my career, but especially now in the current age of social media and people only digesting information in like short bits, like it's become more and more important.
I think that's a really good point because I think our schools, for good reason, focus a lot on, being able to do, particular kinds of data analysis or whatever. But collaboration is a big part of what makes public health happen. And people who are really good at getting those messages out and communicating effectively and communicating in culturally competent and targeted ways are really valuable to our public health teams. And even if maybe, some of the calculations elements aren't your strength, you understand how they work or whatever, but what you're really good at is communicating. I think some of our early career friends can benefit from that message, so thank you so much for talking about how there's a lot to this, and that communication is an important element.
Yeah, absolutely. And continuing in that vein, what are some previous ways or current ways that you've worked on translating your work, either at the community level, policy level, new programs, any type of kind of translational work of like taking what you find in your studies around disparities and around place and health and kind of moving that forward into the world for impact?
So I mentioned before this FAN study, the Female Asian Never Smoker study, and how we're really hoping that we can affect lung screening policy with our work. I'd say like a little further back in my career, I worked a lot with adverse childhood experiences, and um, there was a okay. So I know you guys are already experts in this, but just and probably most of the listeners, but just the concept of how experiences that you have as a child um, kind of affect your long term health. So let's just kind of put it in that broad terms. But physicians were not necessarily paying attention to it, and so there was a big push in California to make screening of these childhood experiences kind of a regular part of a pediatric visit and also reimbursable. And so I think that was exciting to see, kind of like the path from, oh, we found out this is important, oh, but nobody's paying attention to it, to let's push for it. And now it's now I started to see it more in practice. Of course, it's there's bumps along the way, there's drama, there's all sorts of things that happen along the way, but it's nice to see forward progress.
That's amazing. It always comes down to the money. What was your argument, beyond just this is the right thing to do, to making it reimbursable? Like how did you make that argument?
Well, let me just say that I am not the political advocate in front of, in front of the policymakers. Um,
Fair.
my part was more just making the research transparent, evident. And so our team put together a whole slate of, systematic reviews and said, listen, is clearly important. And then the next people in the long chain of work said, okay,
Sure.
we will take this, we will either publish it or put it out there or, bring it in front of the policymakers. And then eventually it happened.
Amazing.
Yeah.
Thank you for that extra detail. So we've gotten a lot of great background, Dr. O, about who you are, what you do, why you do it, and like how it fits into the broader elements of what public health is and why we do this work and how we can make further impact. I'm super interested in your cohort study about Asian women who never smoke. That's super cool. But we'd really like to learn more about the Health Atlas specifically as a tool and you know, big picture, we'd like to learn more about how we can support your work and how we can do, learn from your work to impact our work as maternal child health advocates and academics. But first, can you start out by telling us what is the Health Atlas tool?
So the Health Atlas is this interactive mapping website where you can explore place-based characteristics, so like social determinants of health, um, at a population level across the US. So all 50 states and then District of Columbia and Puerto Rico. Um, it's kind of easier to see than to describe, but I'll leave it at there. The URL is healthatlas.ucsf.edu.
Amazing. Why did you feel this tool was necessary?
So our team kind of thought it through, and we started with a very small, kind of like narrow focus, and we said we want researchers specifically to better understand why population health matters, right? And so we're like, we're going to make this research tool, and we're going to make it as crystal clear as possible that these population factors matter for health, right? Um, and yeah, when we started, we're like, let's just make it for UCSF researchers specifically. We were like trying to think of our specific user. Um, but then along the way, we're like, well, I think we have enough expertise in California. And well, and then just recently, um, we linked with Health Equity Action Network, who has people all across the country. And so we're like, okay, we think we have expertise to make this national. And so
Amazing.
yeah, but we started very small.
Very cool. So what were you were really hoping to help the UCFS researchers initially understand why place matters because you wanted to have them consider that in their development of their research projects?
Yes, I mean we knew that place matters, but we didn't
Right.
necessarily see it everywhere in the research that people were putting it out. But not that it was bad research, but it's just that it could be, a,
It
a
could be
bigger
better.
picture, right?
Yeah.
Um, so we well, funny story is we tried to launch it in spring 2020. And so you might have remembered that time in your life. It was kind of an interesting time, right?
Yes, yes.
Um, so we initially were just like, okay, we're gonna put out these maps and it'll be great, right? But then we started to panic and we're like, maybe we need to wait a few months before we even put this out. But instead, the dean of the School of Medicine, Talmadge King, Dr. Talmadge King, he said, no, we need to add COVID data into the map and release ASAP. And so that's kind of what we did. It was a very stressful March for me because we had to find the data, figure out how we could get the COVID data. We ended up having a partnership with the Los Angeles Times, who is calling all 58 health departments on a daily basis to collect the data, put it into GitHub. And so we scraped directly from their GitHub. And
That's
yeah,
amazing.
actually in 2020, that 5 years ago, we released. And so that is probably a large reason why we went from laser focused UCSF researchers
Hmm.
to every single armchair epidemiologist in the country. Well, to start, we were only in California, but we really thought we would have a narrow user base, but because of the time that we launched, like it kind of blew up.
That's a really cool impact of COVID. Like, I feel like, I feel like some of the narratives around COVID are really limited to what we lost. And I think there's a lot to be said about what we gained from the pandemic, and like how these responses happen. I love seeing, especially I see this in maternal child health, I think, especially because of how narrative driven women's health is. And I'm sure that's some of what you've seen too, and that rather than being like scientifically driven. And so I love seeing the collaboration between the news media and the researchers to really get this data collected and pushed out. So thank you so much for that work and like working across those across disciplines to get this really important work out. But thank you so much. Can you tell us a little bit more about how it was developed? We've talked a lot in maternal health circles about the importance of where people live. Zip code is a predictor of health, redlining, environmental exposures, but it can still feel really abstract. You've talked about how it was developed kind of really broadly, but can you talk about it a little bit more specifically?
Sure. So the nitty gritty is we started by thinking through, what is the data that we want to put out there, right? The simple question, but then trying to figure out all the gazillion places where the data lives. So the census does put out, or census, American Community Survey does put out a lot. Um, at the time, we got a bunch of environmental data from Cal Enviro Screen. Now that we've gone national, we use a different source. There's also CDC Places. So there are some places that put out a lot of data, but then we're like, well, what about this? And what about that? And so in the end, I mean, I think we have over 20 different sources, and a lot of that is curated by our team that kind of thinks hard about, what it would be important to put into this map. And so, okay, so after we figure out where we want to get the data from, we have to pull it and kind of harmonize it to make sure we have the right pieces, and sometimes it's like questions of, well, do we want the state specific factor? We want the national factor, or do we want this index, or do we want the dollar amount? There's like all these questions. And so rest assured, somebody on our team is like thinking through, what is the best data and trying to not confuse the user as well. Because, sometimes you can get, I mean, we have probably like 7 different flavors of like measures of poverty, but
Yeah.
those are the ones that we think might be the most important. There might still actually be more um, out there, but we tried to curate what we thought would be the most useful. Um, so once we kind of put together all the data, we worked together with this amazing data visualization firm. They're called Statement Design. They used to be based not too far from UCSF, in the Mission District. And during the pandemic, they decided they didn't need an office anymore. So, so now we work from, with people in New York and DC and Brazil and also San Francisco. Um, but they have been an excellent partner for us along the way. And I feel like everything we ask them to do, they kind of like make it better. Like they step it up and they like make it better than we could have thought of.
Those are the best kind of partners to
Yeah,
have.
yeah, they've been great. And they're really super fun to work with too. They're just like fun people.
That's amazing. Well, thank you so much for that. Did you guys do some? I love the conversations in epidemiology, like the nitty-gritty conversations about like which data source at which level, at which scale are we going to use. Those are always great conversations. What did you do some beta testing? I have a question here about beta testing, so I'd love to hear about that process if you're able to describe that for us.
So we did different rounds of beta testing. So for the National Health Atlas, we gathered a group, like a smallish group of people who we emailed out, and these are the people the easiest job, just like, hey, can you check this, this, and then they would fill out the form and give us their feedback. But we also, and Indira participated in this, we also did some more kind of like qualitative user testing, so there's user interviews and just to get more granular feedback from users.
Mm-hmm.
And so I think that was really helpful in trying to make a tool that was intuitive. There's still, it's still not perfect, especially since we designed it for researchers, but like a broader audience. It's hard to cater to everybody, right?
Yeah.
But I feel like getting that type of feedback was super helpful because we are so in it. We have been, like soaked in this data for decades or years. Um,
Yeah,
so it's always nice to get another perspective.
for sure. Okay, so we've talked a little bit about researchers, as the design for this, and we've talked a little bit about community across the country, but do you have a way to know who's using these tools and what kind of work they're doing with it?
Well, we do have Google Analytics, so that does give you some sense. I honestly always get lost in Google Analytics because I can get the basics. I can get like the number of users, the number of visits, and things like that, and then they do
Uh-huh.
tell you where they're from. Um, but one of my goals for this year, and we'll see. I mean, this year has been an interesting year for everybody, but early in in 2025, I was like, this year is the year that we start talking to people in the field who are using this tool and like gather these stories. Um, so that is I mean, we have heard from people who have come to us and be like, oh yeah, this is, it made making my presentation so easy, or, we wanted to map out our mobile mammogram van and, it was really easy to use that data. So folks who are in, various different roles who have reached out to us and said, oh, this has been a great tool for us. But what I would like to know is like a little bit more, and then, maybe also some of the challenges that they have with the tool so that as we start to, make fixes and develop more, that we can make it even better.
Yeah. Do you have anybody who on your team who's tracking if this website is cited in any published articles?
That is a good question. We do have a citation on our website that you can use.
Hmm.
Um, we are trying to get out, we're actually putting it together right now, like a white paper, so that
Yeah,
if people do want to cite and have just a little bit more of the background information, that it's just all in one place, rather
that's
than
amazing.
having to kind of ask around and like dig around the website, that just a white paper just to have everything in one place.
That's amazing. I love the plans for a white paper because I think that that's like supports your goals of having it be, really functional for research use. So that's amazing. Our next question is how do you incorporate community voices into the tool?
So in our California version, and perhaps in the future, we will see, in our California version, we did have data stories. And so we
Mm.
would try to tell stories about different communities through data. Um, I would say we haven't gotten as far with the national version. Um, but I would love to, as we are collecting these use cases, I would love to be able to somehow compile those and put them in one place, whether it's on Health Atlas or, maybe on our Pop Health UCSF website, but just for people to be able to talk about why place matters.
Is there any community around this sort of data mapping? Like, is there, um, like, like a committee, not a committee, but like so any sort of organization nationally that sort of brings collaborators in from other universities that are interested in this sort of mapping work?
I mean, I'd say the closest thing that we have to that is the Health Equity Action Network that helped fund the Health Atlas, which I have to say is also kind of at risk given federal funding, like the federal funding situation. Um, there are other groups who have put out maps with population health data. Like we are not the only map out there. We just created the map that we would want, honestly. um,
Yeah.
and I do work with other cancer researchers who are kind of doing similar mapping work, but there's nothing that I know of. If you know of anything, I would love to connect with them.
We
But
should start a national conference for like public health, like data
mapping,
visualization or mapping or something so that we can like
I
work
would definitely go to
together
that
and like
conference.
share resources, right? Right? Because
Yeah,
like I
well,
feel like
if
it's
I
like,
get, yeah, right now we have a funding freeze on travel as well. So sorry, I keep on bringing
oh
up
well,
funding, but yeah, I
big
can't
dreams for
travel.
the future. That's cool. I love that you have a plan for collecting more narratives, for collecting more of the stories of how people are using this, and also for like improving. Andrea, do you want to take over the
Yes,
question?
yes, for sure. Okay. So For any maternal child health professionals who are listening, who want to maybe integrate mapping into their own work, where would you recommend that they start? And if they were to use the Health Atlas, and we'll get into more of a demo in just a second, but just maybe how to start with thinking about place and health and mapping for work.
So I would start with data, of course, and trying to find the data that you want. I would say tools like Health Atlas help get you there a little bit faster, just because we pull from different places. If you are in school or if you have access to training, I would say learning skills in ArcGIS or even Tableau. Tableau does have maps, it's not as sophisticated as ArcGIS, but Tableau has flexibility in other like data visualization capacities. I know these tools are not always free, so if you don't have access to ArcGIS, there is something called QGIS that is actually free. Tableau does also have a public version, which I haven't used as much just because I've sat in UCSF for such a long time. But it could also be more simple. I mean, Google Maps has lots of tools that you can just use yourself. Like if you're mapping out community resources, you don't need fancy training to like put pins in a Google map. Or if this is me speaking as like a person who likes to doodle, like you could even just draw things. Like you can just use a pen and draw things. One of the books that I love is called Dear Data. And it has all these data visualizations that were just drawn on these postcards that these two women sent to each other. I love the fact that they didn't have to use ArcGIS. They didn't have to use any fancy visualization tools, but yet they conveyed a lot of data with a lot of meaning. And so start where you can start.
Yeah, thank you for that. I feel like sometimes in academia we get into our like, oh, we need to use Stata and R to do all of this work. And sometimes the answer is really like the simplest, the simplest way that we can do it is sometimes the most accessible and also the easiest to understand for people who look at our work. So that's great. I think we'll move into the demo of the Health Atlas now. So let's try to describe things in detail because we might have like an audio version and a video version. But yeah, I was thinking we would just go over like a general orientation to the map and how to navigate it, maybe selecting some variables and yeah, anything that you think is important to cover.
So I was going to use slides to start just because I've gotten into trouble using like doing a live demo while on Zoom, just in terms of bandwidth. I am at the office, so the bandwidth might not be so bad, but we can start with slides. Okay. So here's the URL. So healthatlas.ucsf.edu. We have a mobile version, but the experience, the features are richer if you are using a desktop or a laptop. So we already talked through why it's important, but just to say it again, when it comes to health, place matters. And so that's why we made this tool. In the map, you can see over 120 different variables, and these are anywhere from census tract level, which is about 4,000 people, to state. So, if you think of California, that's like 40 million. There's different geographies for each of the decennial censuses. So there's like different shapes for 2010 and 2020. You can compare two variables. You can look at the data distributions. You can select a custom area. So if you have, say, a specific catchment area you're interested in, or if you want a neighborhood that is just maybe a few census tracts, you can kind of select the area you're interested in. You can export the data if you just want to take it and run. And there's also data descriptions for those who really, really want to get into the weeds. Our data is loosely organized around a social determinants of health framework. So we have demographic data, socioeconomic, neighborhood data, environmental data, and health and healthcare data. And the data comes from over 20 different sources. So some of the primary sources are the American Community Survey that comes out of the census, CDC Places, and the EPA Environmental Justice Screen. The map covers, like I said before, 50 states as well as DC and Puerto Rico. Because of the way browsers look, it's hard to squeeze in Alaska and Hawaii and Puerto Rico. And so there's like little buttons on the bottom that you can click on if you want to go to Alaska or Hawaii or Puerto Rico. You can filter. So there's a way that you can like click on the little filter and then check the states you want to look at. You can also kind of like customize what variable you want and like what geography you want. And so you can change it from census tracts to instead county. You can change the variables, and then you can also add a second variable. So the first variable will always be like a blue choropleth map, so like kind of light to dark gradient blue map. The second variable that you add will be like light to dark yellow. So here, so I'm looking at the map. So there's a map of all 50 states, and you can visualize one characteristic. Again, this is like a light to dark blue one. This is poverty among individuals under 18. If you want to add another variable, I'm looking here at uninsured among under 19. You can see these two variables in the map. So in places where it is dark green, that means that there's a higher proportion of poverty among individuals under 18 and a higher proportion of uninsured among under 19. You can also select an area. So here I selected 3 states, so Louisiana, Mississippi, and Alabama. And the website will show you kind of like where that region falls in the distribution. So in the scatter plot, you'll see like a little orange circle. And in the histograms, you'll see this vertical orange bar, and you could just easily see where the data for those states, in this case, fall in the distribution. You can also export the data. So there's like a little icon at the top. You just click, and then you can select the variables that you want. There's also a little checkbox that says export selected areas only. So if you don't check that, you will get data for the entire country, which is not a bad thing. But if you only want the areas that are outlined in orange on the map, you can click that box, and then it'll just give you a customized data set. If you want to export a map, you can. Personally, I usually just take a screenshot, but sometimes I find this tool helpful if I'm working on like a server that doesn't have like a very good resolution, or, in some cases it's helpful just to export a map. And there's also a tagging system. And so you can see that we have 5 different tags. So cancer, children, climate, heart disease, and older adults. And so here in the map, I clicked on children, and you can see that there's a few that popped up. So there's poverty among individuals under 18, poverty among all families with children under 5, and there's a few more variables that are also in that category. I think I won't read every single variable that we have in the map, but just so you have a sense, we have data on age, sex, race and ethnicity, and pretty granular race and ethnicity. So it's not just, for example, so we have percent Hispanic or Latino, but we also have percent Cuban, percent Dominican, percent Guatemalan, percent Honduran. Also for socioeconomic data, we have a few indices. So things like the Neighborhood Deprivation Index, the Yoast Neighborhood Socioeconomic Status, Social Vulnerability Index, just like different ways people have conceptualized socioeconomics across the country. We have poverty and income inequality, employment, education, digital access. In terms of neighborhood data, which is a big umbrella, we have household data, language and ethnic enclave data, housing data.
Just looking at these slides, like I'm overwhelmed by, in a good way, about how many different data sets are included in here. So just for the folks listening, the slides are showing us, all the different data variables available, and there's just so many of them, and they're so specific, and it's really incredible.
It is a lot, I have to admit. But if you are interested in just kind of like typing something into the search bar, that might help you get to the right place. You can also use so for example, if you're interested in children, you can just click on that little tag and that will sort of narrow your view so you don't feel so overwhelmed. Okay,
Sorry if I sounded critical. I didn't mean to be. I was just like, there's so many of the tools that we have available to us as epidemiologists or public health workers tend to be so limited in scope. And so when we're trying to answer a question or show an answer that we already show data that we already know the answer to the question, but we need to show it to, some of our people making financial decisions, sometimes it's hard to find. So I think it's really great that this is so available.
we try to make it as easy as possible to just find things in one place. But again, yeah, you have to kind of strike a balance, right? You don't want every single measure of, I don't know, uh, you don't want every single measure of poverty, but you do want a few. Okay, so moving through, neighborhood data, we have built environment, segregation, structural racism, rurality, transit. We have a bunch of environmental variables, some of which are currently only available for California. We are working to expand that, but there are some that are available for the entire country. So things like PM 2.5, ozone, like air pollution factors, and then environmental indices that are available for the entire country. And most of the health and healthcare data is taken from CDC places, but there are a few that are taken from other places. But we have health outcomes like arthritis, asthma, coronary heart disease, and then healthcare access, healthcare use, health behaviors, disability, mental health. And I think that's it. So I think this is my last slide, but I just wanted to again say that this was a team effort and we definitely needed every person on this team. So big shout out to Stamen who helped us kind of like pull this all together and make it user friendly and beautiful. But we also had a lot of people who helped us just fund the project or, to make sure we're highlighting certain data, giving us expertise on, what data sets would be important to include. So we needed everybody.
I'll just say, because I interned for you, Debbie, if people wanted to find more information on some of the indices that are used, like, so for example, we saw on the previous slides, there are some measures of income inequality and segregation, and people are interested in learning more about how those indices are created. So if people wanted to learn more about what kind of goes into creating like these types of indices that are on the map, where might they find more information, Debbie?
So there's a feature on the website where there's like little tiny circles that are gray that have an eye on them, and they might be a little hard to see because we tried to cram in a lot of stuff into the map. But if you click on those eyes, there's data descriptions. So for every single variable, there's information on, where it came from, why it's important. There's some references too, because again, our initial audience primarily was for researchers, and researchers have all these questions, like, well, where's the data from? And, why is it important? And so it's all there in the website. However, if you have additional questions, you can email us at pophealth, so POPHELHEALTH at ucsf.edu.
Great. Thank you so much, Debbie. And we both want to thank you for just breaking down your work, your experiences, and also a really complex and wonderfully rich tool that you've worked on developing and that we've worked on a little bit together, and making data and data for public health equity feel both accessible and also meaningful for not just researchers, but for folks who are interested in working in public health and advocating for their communities overall. So your work is so important, and we want to thank you so much for coming to our podcast and talking about what you do. And we
Thanks for
look
being
forward to
brave and
hearing
doing
more
your
about
first
your work.
podcast ever.
Yes, thank you. It was so great to talk to you.
Fun. Thanks for inviting me.
Thank you so much, Debbie, and goodbye from the Maternal Child Health National Network.